Right. So we've got three different speakers, a fair amount of material to cover, so the idea is to try and get through a fair amount of pearls very quickly so you have a fair amount of good take-home information. Who's queued up first? Do we know?
It's whoever would like to go first.
All right, Bill, you want to start, or? Okay. I know Bill's got some very interesting articles I'll quickly go through.
Let's see, for getting me on.
Trying to keep me around.
I got another confirmation our broadcast is good.
Whoa.
It was.
It was good. Is that you, Bill? No, it's like, it's loaded for some reason. There you go.
Okay, today my goal is to go through, there's just so many new important studies that have just been published in the last month or two. So going to hit some highlights on a variety of articles on new biologics, new indications in both kids and adults, and focus on the new therapeutic areas and long-term safety data. No disclosures. So to dive right in, the first one I wanted to describe was this phase 3 studies that led to the approval of dupilumab for patients with chronic rhinosinusitis and nasal polyposis. There were two large studies that were top one there, 24-week treatment period, and then a 24-week off period. That was Sinus 24. And then a longer study of 52 weeks of treatment, and the Sinus 52 study. The differences here of the second study is they went from a Q2-week dosing to a Q4-week dosing. That was one of the comparators of that. And in these patients, they were on poorly controlled chronic rhinosinusitis with polyps, and as a baseline treatment, they were all on mometasone intranasal spray, so the dupilumab was added on to that. And this was approved a couple months ago for the use in nasal polyposis in this study. But this paper that it was based on the approval just came out last month. So there was just a ton of different endpoints that were looked at in this study, from questionnaire data to monitoring the nasal polyp size by CT, nasal opacification by visualization scores, and I'll show you in a later one. So this one is looking at the change in the nasal congestion obstruction. And you can see that this was the primary outcome of the study, and the dupilumab groups you can see were quite significant over the time. When they were stopped in the earlier study, there was a return toward the baseline symptoms, but it didn't quite achieve that. So very significant results. And this one was looking at the sinus CT score, this Lund McKay score in the upper panels. And here again, you can see that there were dramatic, the blues are the dupilumab groups, dramatic reduction in the CT scores in both of the studies. I should note that when they were looking at the studies, the Q2 week dosing was superior to every month dosing for reduction of the CT and the opacification. It didn't make any difference with regard to symptom reduction. They were equally reduced, whether it was every 2 weeks, every 4 weeks, but there was a superiority for more frequent dosing. And then one of the other, this was a secondary endpoint, but the time to the first systemic corticosteroid dose in these patients, you can see that in the dupilumab group, blue, that was markedly reduced compared to the comparator group that was just treated. They were all treated with just mometasone intranasal, so in comparison to that group. So adverse events.
Is this the 200 or the 300?
This was the 300, I think, right?
I don't know. I find it very confusing.
Yeah.
My thought is to give everybody 300 for every indication. It makes it easier.
Yeah, it's hard because
Right.
each is different biologics, some are dose ranges, so I got very confused with the dosing too through that. But luckily, the safety profile was great. And similar to the atopic dermatitis data, there was increase seen in conjunctivitis in the dupilumab treated group. But none were severe in these situations.
It's interesting because people have been saying that you only see the conjunctivitis symptoms with the atopic dermatitis, not with asthma, and the presumption is that there's something wrong with the ocular conjunctival epithelium in people who have atopic dermatitis. Not true of people who have respiratory disease.
Right, this one is with people with
that.
chronic rhinosinusitis.
Yeah.
The next study I'll show is similar. It doesn't show the conjunctivitis with dupilumab in a different group. So one patient did have the EGPA during treatment with dupilumab, but also there were 2 patients in the placebo group that also had that when they were in the context of steroid reduction. So this has been observed in a whole bunch of other different prior drug trials, like Singular has been associated. It's any kind of corticosteroid sparing agent has the potential of unmasking, what we formerly call Church-Strauss syndrome, is the eosinophilic polyangiitis. Similarly, so there's no difference between the group. Could always be aware of that treating these patients. So these are the take-home points, and you can see that there were like 10 different parameters that were followed in this study. So provided early clinically significant improvement across all aspects of disease, reduction in systemic corticosteroid treatment, and decrease incidence of surgery. The loss of smell improved. So there was reduction in that, in the anosmia, and polyp size was reduced. Then they also looked at, since as you know, in this setting, a lot of these patients have comorbid asthma. And they also showed that those patients that did have decrease in respiratory function in this setting, they also had improved lung function and asthma control. And then they looked at some biomarkers. So dupilumab decreased the type 2 markers. Total IgE was reduced. The CC chemokine TARC, CCL17. And these are in the blood, and eotaxin 3, major chemoattractant for eosinophils. And in the nasal secretions in the subset, they showed that eosinophilic cationic protein and eotaxin were also decreased, so showing that effect in the airways. And like the asthma studies, dupilumab does cause a transient increase in blood eosinophil levels, so it probably blocks the movement of eos into the tissues. So for early parts of the treatment phase, you will see an increase in blood eosinophils. That did return to the baseline levels after a couple months. So a lot of data to go through there, but it's a good study to review. And actually had a patient yesterday with CF who has chronic rhinosinusitis. It'd be interesting, that patient didn't have nasal polyposis, but most of the CF patients in my experience have nasal polyposis. And I found one paper that IL-13 level has been associated with nasal polyps in children with CF, so that may be I don't know if you could, it'd be an interesting therapeutic use in this, since this is now approved.
Do patients have to have polyps at the time you apply for the drug, or have a history of polyps? They've had them surgically removed previously? Is that a good enough indication?
I think you have to have,
Polyps active at the time?
yeah.
Yeah.
But like anything, you can try for the approval. So this one, just brief note, this came out in gastroenterology this past month. So this is a phase 2 study with dupilumab in patients with EoE, and it's actually the first to show symptom reduction with a biologic. This study has some problems, and I'm sure they're going to work on that for the phase 3 study. Basically, it was a 12-week study of dupilumab. This is 300 milligrams sub-Q, and it was every week with a 600 milligram loading dose. And then they had a follow-up period after that. And the primary, so these are adults with active EoE, 2 dysphagia, pretty symptomatic, 2 dysphagia episodes per week, and typical, 15 EOs per high power field to make it into the study. And they either got placebo or the dupilumab injections. And then the primary endpoint was this, it's called a Stroman dysphagia study. In their discussion, they described it when they read up the study, I don't know, maybe 5 years ago. This was about the only instrument out there. It's not validated. And since it got published, there actually is a validated EoE questionnaire called the EoE specific ProScore that they use as a secondary endpoint. But this was actually, this non-validated one was their primary. And then they looked at histologic features of biopsies before and after the dupilumab intervention. And interesting, they also did another novel kind of secondary endpoint of looking at esophageal distensibility, how flexible increased distensibility of the esophagus after treatment.
How do they do that?
It's indeed kind of a device. And so, just it hadn't, they're again not validated in large studies, but probably new, very interesting article to read of how we'll be assessing EoE in the future. They're trying to validate a variety of parameters. And you can see that their primary endpoint was achieved. It was significantly reduced. The lower group is the symptoms of dysphagia episodes during the study, the 12-week study period with dupilumab. And in this Stroman questionnaire, in their prior studies of that group, they'd said that if you had a mean value of 3, a reduction of that was considered significant, and it did achieve that in them. You can note at the bottom of that, they got about a 20% increase in esophageal distensibility. So that was pretty nice. And then looking at the histology, all the ones, the placebo group after treatment, the arrows are pointing at eosinophil staining, and couldn't see any eosinophils after week 12 in the dupilumab treated group, and that was seen when they counted them, dramatic, very significant reduction in tissue eosinophils during the treatment period. And that also correlated with endoscopic features. There were some problems with the study. They had a technical glitch. They had electronic diaries monitoring the dysphagia. In week 12, they something in the central repository, they missed a whole bunch of their data points. So luckily it was still blinded, and they revised their primary endpoint to 10 weeks. So it decreased the power of the study. And as I said, the secondary endpoint of a validated, this eosinophilic esophagitis validated questionnaire, it had the same sort of curve as that showed, but it didn't reach significance, like p equals 0.08. So they didn't need a larger study in their phase 3, but it's the first, really good data here. In there, they didn't see any conjunctivitis in this patient population, but they're in a small number of patients.
Why should this work? You would think the other new biologics that target eosinophils directly would be better candidates for this disease.
Because the EOE, is a multifaceted disease, and these patients also had comorbid atopic diseases. They had maybe more than half had food allergies. Sort of the typical range that we tell people empirically to avoid if you have EOE, so milk, soy.
But they actually have food allergy, or, because I find whenever I have adult patients with EOE, none of them are skin test positive. And so it's food related, but it's not classic IgE mediated.
Right, in this patient population, they had strong atopic comorbidity. So suggestion that IL-4 and IL-13 signaling could be targeting other things and not necessarily just the eosinophils in this disease. The other thing that brought up was interesting. There's a really high failure rate of entry into these EOE studies. About 40% didn't make it in, and I guess that's typical across all. So it's going to be difficult, to conduct a phase 3 study. So this will be very quick. Benralizumab has been looked at. There was a former, in COPD, you get eosinophilia. This has been associated with exacerbations, and it's also been associated with response to intranasal, inhaled corticosteroids. And there were 2 mepolizumab studies in New England Journal a couple years ago, and one showed reduction of COPD exacerbations in patients treated with mepo, and the other study did not show that benefit. So in the larger study with benralizumab, they entered the 2 studies of long-term treatment for maybe, I think it's total of like 3,000 patients in the 2 studies, trying to see could you have significant impact on COPD exacerbation. So requiring, what they define as exacerbation is requiring systemic corticosteroids, or if they've had a hospitalization or required antibiotics for that, and see if they could have an impact. And in this studies, the 2 big studies were called Terra Nova and Galathea, and they were dose ranging. One was at 30 milligrams treatment, and the other one was 100. And bottom line, this is an New England Journal paper last month, that there was no significant impact of this anti-IL-5 intervention on exacerbations on the primary endpoint, looking at patients who had baseline EO counts of 220 or greater. And they did a pre-specified subgroup analysis, and when they stratified via eosinophil levels, it didn't make a difference there again either. They couldn't identify a treatment effect in that. But however, a couple of weeks ago in Lancet, they did a further analysis of all these data. So they're still wondering, are we missing something here? Because all the data suggests that it should be having an impact. And so this is one of the most complicated papers I've ever read, because they looked at lung function, exacerbation rates, eosinophil counts, and different dosing of benralizumab, and then they did matrices of these, all the little forest plots, and about 15 figures later is really an interesting summary slide. So it shows that actually there is probably a subset that may respond to benralizumab in this group. And if you walk through it, it turns out that the key thing is you need greater than 220 EOs per microliter. And then these are all the reduction in the rate of exacerbation. So the higher you go, the much better response. And if the patients are on triple, in the study, the previous said you could be in either inhaled corticosteroids or a LABA or a LAMA. But they found if you're on all three of them, that increased your response to the benralizumab. But the biggest one is that their entry was 2 exacerbations. It turns out if you have 3 or more, then that's a big jump up in that. And then if they have a post-bronchodilator response of greater than 2%, it adds it even further. So you can actually get over a 40% reduction in your exacerbations if you have all those different combinations. And I looked in clinical trials, and they've now designed a trial to explore that. So COPD, third leading cause of death in of all patients. So a big target area here to have a major impact on their quality of life. So I think I've got a couple more, but probably exceeding my time here.
All right. It's like they were trying to make the best they could out of a failed study.
Yeah, and it's actually some hope there. Yeah, also you need the 100 milligram dose, so 30 milligram didn't do anything. So it just shows you how difficult it is to do a clinical trial, and it's always important to keep analyzing your data because there's important things there that make a difference. Just to note that kids now are approved for mepolizumab for severe asthma, and that was a Jackie paper in press this last week. That was approved about a month ago or so for kids 6 to 11. So it's just showing that the children had a marked reduction in their eosinophil levels. They bumped back up, but don't go toward baseline in the observation period. And then with the long-term treatment, the data would show that it was quite safe. No induction of anti-mepolizumab antibodies. So I'll point you to the other couple of papers to look at down the road, because there's some other things. This week in New England Journal there was the new, more potent anti-allergy that was shown to be superior to omalizumab in a phase 2 study with regard to achieving complete response of urticaria.
I just wondered other people's opinion on this. Obviously this is a controlled study, which is better than open observation, but when I put people on omalizumab, I'd say 80% of them do well. This paper showed much lower response rates, which just didn't match with my clinical impression.
And they had in their discussion, they talked about that because historically the omalizumab group was less responsive in this study.
Yeah.
And for some reason in enrollment, they had a higher incidence of people with CU index, so more autoimmune disease across the board in all the study groups. So it was a multinational study, and those patients tend to be less responsive to antihistamines that are the anti-FC epsilon receptor antibodies. So
I'm just curious, other people in the room here, I mean, the response rate I see with omalizumab is so good, doesn't match with this paper. But again, at the outset, I was saying we still throw around unproven comments like the one I just made. Sarah, you want to go next?
Sure.
All right. Okay, we'll save time for you, Paul.
Oh, yeah, that's perfect.
Bill, what was the word of the day? It was your first slide. What was the word of the day? It was your first slide.
Biologics.
She said she wanted the slides.
They go automatically.
Where'd that opening slide come from? Like climbing the mountain? Or-
I think it's the background for the computer.
It's not one of you fellows.
No, it's not great. That's what we do on our spare time. Too much free.
That's what it's like to make. That's what it's like.
All right. So I just chose kind of a smattering of 3 different topics for journals. I'm Sara, if I haven't met anyone. So the first one, this isn't super recent. It came out last year, but it's inhaled combined budesonide and formoterol for as needed in mild asthma. And so I know we kind of went over asthma last week, so this is just kind of a little bit of a background slide. Just saying that even though most people have mild asthma, they still remain at risk for severe exacerbations, and they make up a pretty big amount of the patients that are going to the emergency room and then requiring oral steroids. And so what they did is they randomized patients into 3 groups, so it's called the Sigma trial, and they were using as needed an ICS LABA, which really ended up being Symbicort. And so they had 3,800 patients, and so they were split evenly into either just using an as needed SABA, so just albuterol PRN, and they were given a twice daily placebo. This as needed combination, which they were giving a twice daily placebo, and then at the first sign of symptoms, they would start their this ICS LABA, and then ICS maintenance, where they were just continued on twice daily ICS, and then had their as needed SABA. And this is and so, my slides are like, sorry. And so the way that they randomized them, they needed to make sure that they were appropriate. They had to be GINA step 2. And so they did a 2 to 4 week washout before. And so they just gave them terbutaline PRN. And if they were using that more than 3 times a week, or if they were requiring it very frequently on each individual day, then they were ultimately randomized into the group. And so if you can see here, they kind of look at the how well controlled their asthma was. And so up here is the maintenance, and here's the budesonide formoterol as needed and the terbutaline as needed. Oh, I'm like using my mouse, but I guess you guys can't see that. But ultimately, the when they kind of look at it over on the first graph, is there a pointer?
Is there a pointer? A mouse
Here.
up there? Or?
Can you see this work? Laser pointer. This? Yeah, there. So over here, so the budesonide formoterol PRN was superior to the terbutaline when you were looking at your well-controlled asthma weeks. And this one over here was superior, but it was not significant when you're looking compared to the ICS maintenance. And so then when they're looking at the when they did a post hoc analysis and looked at how well, like their well-controlled asthma, you can see here that between the groups that it was better than the as needed, and there was not much of a significant difference when you looked at the twice daily.
How did they blind this study? You would think one group would only have 1 inhaler.
So they gave them all, so they all had a twice daily, so these 2 had a twice daily placebo, and then their PRN, this one ended up being a SABA, and this one was the ICS LABA. Ultimately, this was like a single, and then this was the, they just gave them the twice daily ICS.
So everybody had 2
Yeah.
inhalers, but 1 was placebo.
Yes. And then that was the confidence interval. And then if you look at their actual asthma exacerbations, this is pretty small. But ultimately, the as needed group had a 64% lower rate of severe exacerbations compared to the, and they resulted in a 6% lower rate of, compared to the terbutaline as needed. These are really small, and so you can see there that's significant. And so this is compared to the maintenance, that there was not a significant difference when you compared it to the maintenance. And then the time to first exacerbation, same thing. You can see over here that the time to first exacerbation was much higher if you were just on terbutaline PRN compared to the other 2, the as needed as well as the daily maintenance. And ultimately, the difference is when you look at how many inhaled they all complied the same, which was about 79%. But you look at the total number of, how often they were needing, or had the total amount of steroids that they needed. That's the type of steroids, and then their adherence. Yes. And so the total number of the total amount of steroids that they got, which is always the main concern of patients, was ultimately a lot less, despite giving them, they didn't give them as good of control, as the twice daily, but they still gave them pretty similar control without a significant difference. And then the total amount of steroid that you're getting is significantly lower, which is what a lot of patients are always really concerned about when they are using some of these inhaled steroids. Let me scroll later. Anyway, so so doing it PRN is more effective than SABA alone. It's superior in both symptom control and prevention of the exacerbations, and then it was equally as effective as budesonide maintenance in the prevention of moderate to severe exacerbations. It was inferior to the maintenance therapy in achieving the electronic reported weeks of control, but they were receiving a total of 1/5 of the amount of inhaled glucocorticoid. And so then this kind of jumping course, this was published in JACI, and it's looking at antibiotic allergy labels in children. And so I know there's a lot of data published in adults looking at antibiotic allergy labels. And there's not as much in children, seeing how this affects, their hospitalizations, as well as what kind of antibiotics they're getting. And so it's reported that about 6 to 10% of patients have pediatric antibiotic allergies. And so in adults, we know that it increases hospital stay. They require readmission, they often receive second-line antibiotics, and they're at increased risk of clinical complications like VRE and MRSA and C. diff. And then you have increased cost of use just because you're using more expensive alternative antibiotics. And so this was a single center study that looked at 1,600 patients. This was in Australia, and so they did and so they were looking at their demographic, antibiotic allergy labels, their admission diagnosis, which antibiotics were prescribed, their length of stay, and then how often, and then their readmission within 4 weeks and 6 months of discharge. And pretty much anyone that had any kind of allergies or adverse reaction was kind of initially pulled as having an antibiotic allergy. And so they were kind of separated depending on, what their symptoms were via chart review. And so then they were classified as anaphylaxis, angioedema, rash, or non-specific. And so numbers 1 through 3 were considered allergic, and then 4 and 5, the GI and the non-specific, were not considered allergic. And the large majority of these patients, about 81%, had a reported rash, and then 13% had anaphylaxis. And so then when they were looking at the presence of an antibiotic label, so any allergy label, beta-lactam or penicillin allergy, it was significantly associated with prescribing alternative antibiotics. So as you can see here, this is looking at the percent on macrolide, so this is if they had any. So this is any antibiotic in the dark blue, beta-lactam in the medium color, and then penicillin in the light blue. And so they were more likely to prescribe macrolides, quinolones, nitronamazole, and then lisinopril, sorry. And so as you can see, just overall, there was a significant difference. And so they were significantly prescribed fewer prescriptions for amoxicillin, and then they had the higher use of azithromycin, Cipro, Clinda, and metronidazole among people that had beta-lactam allergy labels. And then overall, the impact, they found that it was significant both in the hospital length of stay as well as in, so any antibiotic allergy as well as if you had a beta-lactam allergy was significant for your hospital length of stay. And so ultimately, any antibiotic label was associated with, it was 5 days versus 3.8 days, and then beta-lactam was 5.2 versus 3.8. So just something to consider, especially because a lot of kids will break out in rashes when they get particularly amoxicillin or penicillin, and so trying to best clarify, moving forward, was that a true IgE-mediated allergy or not? And kind of, kids don't get admitted very often, but there is that subset that do and get a lot of admissions, and then you might not think much, once or twice about it, but it's just something to consider.
Well, important, did they test these kids and prove they weren't allergic?
They didn't. This was more so just kind of looking retrospectively, but there really isn't a ton on, how this affects kids long term. And even in general, we know that adults if they have an IgE-mediated allergy after 10 years, that really decreases. And so a lot of these kids, they weren't tested. It was just based on like what was reported in the chart for that. And then the last one is from the New England Journal, kind of flipping pages just because this will likely be coming out soon. And so this is the AR101 for peanut immunotherapy. And so there's currently no FDA-approved products, and it was a double-blind food challenge. So they took all these kids and they gave them a double-blind food challenge, and so they tolerated less than 30 milligrams of peanut protein, which is a fraction of a peanut. It's a tenth of a peanut, and so they randomized 555 patients in a 3-to-1 ratio, receiving either AR101 versus placebo. They were started at 3 milligrams, up-dosed every 2 weeks to a goal of 300 milligrams, and that was continued for 24 weeks. And so one peanut is about 300 milligrams, so that was roughly what they were receiving daily. And then they underwent end food challenges where the total dose was the final dose that they took at once was either 300, 600, or 1,000. And so these were the cumulative doses because they kind of built up from there. And so they were looking at how many patients tolerated these end doses based on your original one of tolerating less than 30 milligrams. And so, as you can see here, these are kind of the baseline characteristics. So they all had pretty big skin wheal sizes. They were between 11 and 12 millimeters. Their peanut IgE was pretty high in the 60s, 70s. And their maximum tolerated dose on their initial was 10 milligrams, which is about a tenth of a peanut. And then a lot of them had prior anaphylaxis, and then a lot of them had multiple food allergies. So looking here at kind of some of the results, so on AR101 versus placebo, this is looking at your IgG over IgG4, and so your IgG4, technically, if your dosing tolerance should be going up, and so as you can see, the ratio went down compared to the placebo. And then same thing looking at their mean skin wheal size, that also went down in the AR101 versus the placebo. And then this is looking at the exit food challenges. So as you can see, the amount in the placebo versus the the placebo versus the AR101 that tolerated 300 at the end, 600 at the end, and 1,000. So it was still about 67% were able, so their end goal was 600 milligrams. So 67% of the kids were able to tolerate, in the AR101, were able to tolerate the 600 milligram final dose. And there was sorry, I'm on the pointer, I can't go over my notes all the way. Whatever. But it was slightly less than they were able to tolerate the 1,000. And then this was, they had done 18 to 55, but it was a much smaller group, as you can see, 41 and 14. And so they did not reach significance in that. So I don't think it's going to they're not submitting for approval for this. It's just going to be for this. And then overall looking at, the doses during the exit food challenge and what happened. So this is how many kids in the placebo were actually able to tolerate every individual dose before stopping. The red is severe anaphylaxis, and then moderate, and then mild symptoms. And so as you can see here, even the amount of kids that were able to tolerate was much higher, or the percentage. And then also if you're looking at the reactions that occurred at each dose, they were much less severe compared to this group. Then the only really main thing about these is, looking at, these are the adverse effects, and so one of, the side effects, you are ingesting this, and so most of the problems that are occurring in the updosing phase, and seeing the percentage that are having a lot of kind of these upper abdominal vomiting, oral pruritus, and symptoms compared to the placebo. And the same kind of goes here, and so one of the important things to consider is during the course of the trial, excluding the food challenges, 52 participants in the active group, so 14% compared to 6.5% in the placebo, required epinephrine treatment. And so most of that is occurring during your updosing and your maintenance, and you can see here kind of the severe reactions that occur during updosing. And then this is kind of, again, looking at the treatment emergent adverse effects, and then the ones that are severe, and you can see those here. And then the withdrawal, again, that is kind of one of the biggest reasons why people ended up withdrawing from the study, was because of these acute, chronic, or recurrent GI, and then they ended up having 16 of the 24 patients. So they had 24 patients withdraw for GI. 16 of those were the ones that were having, this chronic, recurrent, dose-limiting GI symptoms, and 3 of them ended up undergoing EGD, and EOE was confirmed in 1 of the patients, and then an additional 8 of those 24 had kind of more acute adverse events. And so again, there was a significant difference, and so it definitely was able to raise the threshold of their tolerance of peanut, and it'll be interesting to see kind of how this plays out. There's definitely, you have to weigh the risks and benefits of the adverse events of the medication, but it'll be interesting to see how this plays out in regard to the approval.
Did they exclude very severe anaphylaxis histories at the outset, or they took all comers?
I need to look back and see. I can't remember. I'm pretty sure they took, because you had to qualify via the food challenge, and I think they may have excluded, I think maybe if you required more than 2 doses, a certain amount of epi.
They took the risk.
Yeah.
This part of one of the study groups was here. I wasn't directly involved, so I don't know, but I have a feeling they did exclude life-threatening anaphylaxis.
No, I mean, they definitely treat epi, but I think the amount of epi that, I think if you had a really severe reaction at your food challenge, you were probably excluded. But so a lot of them definitely required epinephrine treatment, and that was not an exclusion criteria.
One of the problems I know anecdotally is whenever a kid gets sick, the threshold changes and the dose that they were taking all of a sudden is not safe anymore. So this is a moving endpoint. The other thing is I have no idea what they're going to price this product at, but again, at the Northwest Allergy Forum, there's this fellow who has an MBA as well as a medical degree, and he sort of calculated society's value of this product, and my take on it was that it's much lower than this company has any intention of marketing this product at. Still telling people avoid it and have an epinephrine injector, the cost to society of that versus this, the balance is still much cheaper for society to just keep doing what we're doing. And I think Paul actually has something related to that, sort of cost analysis of things that we do in medicine.
See what people think about that.
So, yeah, since it's coming, likely will be approved later, or in the early winter, midwinter, January. It'll be interesting.
Felt like midwinter today.
How it plays out. You should just click the PowerPoint at the bottom. You should be able to just pull up your slide. Yep. And then if you put it in
It's already there, so.
Oh, just to put it in.
Oh.
So now you can see it on the other.
Okay. We've had a lot of conversations about cost of medicine and everything, and I just happen to have 2 friends in Canada that are very involved in Health Canada and their approach to trying to control costs in Canada. So that's sort of why I picked one of them. The other is I have a patient that I was sent to see if they're having an adverse reaction to Xeljanz, and that was the first article. It's 5 years old, but it just goes to show that what we're doing is often different than what we think. So I have no disclosures because I'm old and I'm getting to retire, so I don't have any disclosures. But my first patient was a 25-year-old male, 5-year history of plaque psoriasis. Topical steroids were only partly helpful. He had a lot of involvement of his disease. He was on pretty high doses of topical steroids, and they thought that maybe he should try adalimumab. And he started that, and over a year his psoriasis improved, but then the improvement got sort of faded, and he started noticing evolution of his alopecia areata, and it evolved into alopecia universalis while he was on adalimumab. So he had no family history of either psoriasis or alopecia, and they're just deciding what can we do for this guy who's failing therapy. So they looked at Xeljanz, which is a JAK1/3 inhibitor, and they thought since it can treat both psoriasis and alopecia that they would go ahead and give him a try with that. So it had multiple effects on lymphocytes. It thought maybe it could work for both diseases. It was oral and injectable, so they put him in the oral form to see whether that would improve his disease. So with psoriasis, the thought is it's an upregulation of IL-15 expression, and that may be what's causing the epidermal hyperproliferation. And tofacitinib, which is the Xeljanz, has been shown to downregulate that response. And there's some mouse data that shows that alopecia is a CD8 cytolytic pathway and upregulation of IL-15 in the outer sheath of the hair follicle activates a destructive pathway with cytolytic T cells and interferon gamma to destroy the hair follicle. So that also has been shown to be inhibited by these JAK1/3 inhibitors. So they went ahead and started this patient on the Xeljanz, and after 2 months at 5 milligrams twice a day, there was a modest improvement in his psoriasis, but he started noticing partial hair regrowth in his scalp. So they decided that since Xeljanz had been used at 15 milligrams twice a day in refractory psoriasis, they'd increase his dose to 10 milligrams in the morning and 5 milligrams at night. Now, unfortunately, I was seeing this patient at that point for supposedly an adverse reaction to his drugs, and they thought maybe this was a weird side effect. And after 3 more months, he had complete hair regrowth in his whole body. So his alopecia universalis, alopecia areata, everything came back. Axillary hair, eyelashes, facial hair. And at 8 months, he had full regrowth of all his body hair. So here's a guy getting treated for psoriasis, and he ends up growing back all his hair. So when we start messing with these pathways, we don't really realize all the things that happen. And I remember when the speaker last week talking about how all these inflammatory pathways end up with like 2 or 3 mediators in like the entire body. And when we start doing this, and all of a sudden we get these side effects that we wouldn't anticipate. Now, a lot of times the side effects are bad and you start worrying if there's going to be an attorney calling you, but every once in a while you get a side effect that's really good. So this man, when he came to see me in follow-up, said, you know, do you want to change the dose of your drug, see if we can get better control of your psoriasis? He had no interest in changing his drug whatsoever. He just wanted to stay on his Xeljanz, and I followed him for 2 years. He's never had any regression of his alopecia, still has total body hair, still on Xeljanz at this dose for his psoriasis, and he has no interest in ever changing. So it's just an interesting side effect of these new biologics, and it just shows that we have some pretty serious issues with these drugs because we don't exactly know what we're doing with all these medications. We know what they do in one disease, but what they do in another disease is totally unexpected and usually bad from my standpoint, but in this case, it was actually really good. So the drug companies, as you can guess, are pretty excited that they have a sort of a golden goose egg here that they can fix alopecia. And even worse than male pattern baldness in the initial study. So now I'm studying it topically to see if this is something that can be exploited into a very lucrative commercial success, which is what they're hoping. And it just shows that when we treat one disease and we treat some pathway, we don't know what that pathway does in other diseases. So you inhibit one pathway with a drug, and all of a sudden another disease entity is totally affected when we're either good or bad. And this article was written in 2014, and I didn't know anything about this until I saw this guy about 6 months ago. Finally, after 3 years of just being on this drug, and he said, is there any chance this drug is it? So we looked it up, and sure enough, there's this really weird history of these drugs, these JAK inhibitors, causing a really good side effect, which is total regrowth of body hair from actually alopecia universalis, which there's no report of any drug that does this. So it was sort of an interesting anecdote. But I actually saw this guy, so I thought that was actually pretty cool.
I don't get why he was sent to you.
He was sent to me because they thought he was having a bad reaction to the Xeljanz. And that was before, he was just having rashes and itching, and they wondered if it was an allergic reaction. And then all of a sudden his hair started growing in all the places he was itching. So they initially thought it was just an adverse drug reaction. That's how I got involved, and I just followed him because when his hair came back, I thought this is actually pretty cool. But I wasn't bright enough to figure out that it was the drug. I just thought that was an interesting side effect. So the second one is 2 of my friends in Canada are actually involved in Canada Health, or Health Canada as they call it there, which is their national healthcare system. And one of them is actually on the prescription medicine price review board. So he gets into these conversations with me all the time about what's happening in Health Canada and what's happening in the United States. So they've got an amendment pending to try and control the rapidly rising cost of drugs in Canada, because Canada is now the third most expensive prescription drugs in the world. The United States is clearly #1. Canada is now #3. And what they do is they've been able to control all the costs.
#2.
I don't remember who is #2. But it didn't matter because these guys told me they were #3. So Anyway, the Canadian government, because it's a universal healthcare and government-controlled system, they've been able to control all costs of healthcare except for one, which is pharmaceuticals. So they know that the reason that their healthcare spending is going up so quickly is directly attributed to pharmacologics. It's not delivery of care, it's not salary, it's not hospitalizations, it's actually drug cost. So what they've done is they've realized that there's a sort of an out-of-control escalation in drug costs, and the pharmacy industry has evolved very significantly in the last few years, mostly with biologics and genetic therapy, which are the fastest changing areas. And unfortunately, these amazing drugs with amazing potential also come with amazingly high prices. And this is what's sort of pushing our healthcare system to the limits, both in Canada and the United States. So not only do we have these opportunities to treat diseases that are really difficult to treat, but because of the very high cost of these drugs, it's actually putting the sustainability of any finite resource-based healthcare system at risk. And the Canadian government is now feeling this, not as much as we are, but they're experiencing the fastest price increase of any country but us. So they decided that they needed to come up with a pricing and reimbursement model to help evolve, to give appropriate patient access to these newer drugs while not bankrupting their healthcare system. So they came up with a Patented Medicine Prices Review Board, or the PMPRB, and it has the power in Canada to evaluate every new drug. And the task mandated from Health Canada was to ensure that patent holders don't abuse their rights by charging excessive drug prices during the patent monopoly period. So at this point, the Canadian government determines what your maximum list price can be to sell a drug in Canada. And this board has been sort of stretched thin now because they're tasked with all medicines in Canada, but the ones that are causing the most controversy are basically these new drugs. So they've come up with two parts to the system. One is a scientific review, which determines the indication of the new drug, the level of therapeutic improvement versus current therapy, and then they establish comparators to the patented medication, and then this becomes part of the selection guide used to set a maximum list price. The pricing component looks at comparative drug prices in each product from a survey of the specific drug prices in 7 representative countries outside of Canada. They use comparative prices in Italy, France, Germany, Sweden, Switzerland, UK, and the US to help determine the maximum list price that they should charge. The initial intent of this system was to keep patented drug prices in Canada consistent with prices of the other countries. But despite utilizing this system, Canada is now getting the 3rd highest prescription drug prices of the 31 organized countries in the Organization for Economic Cooperation and Development. So the Canadian system is struggling to pay for this, and they're wondering if this committee is able to actually do what it was tasked to do by Health Canada. So they've come up with an amendment. In May of 2017, Health Canada proposed amending the charter for this committee in 5 different areas. The 2 biggest components are introducing an economic factor tool called a cost-utility analysis to determine if a pharmaceutical price is excessive after evaluation. And number 2, they amended the list of countries included in the price comparison to 12: Austria, Belgium, France, Germany, Italy, Japan, Netherlands, Norway, South Korea, Spain, Sweden, and UK. And they removed the United States completely from their comparator analysis, because they feel that our prices do not reflect any of the other countries. And they think our prices are way too high compared to the rest of the world. So again, I'm sure there's people in the back there that don't like what I'm saying. But at the same time, we really can't risk our entire healthcare system for the cost of pharmaceuticals. And that's basically what the Canadian government is trying to prevent.
Do we know, I'm wondering why the Canadians are reinventing the wheel here. All those other countries that are in their comparator, they have a system already worked out that is extremely successful. They're not going bankrupt.
Well,
Drug price.
again, I didn't get into that, and that wasn't in the article. This is a JAMA article, but Steve is a hospital administrator from Victoria, and Jack is actually part of this prescription medicine review committee.
Your friends.
These are my friends in Canada.
Yeah.
So most of this stemmed from their arguing with me about why are we crazy in the United States. So they didn't really get into a lot of that data. But this is just their attempt at trying to control these runaway drug prices. And you mentioned last week that we need to be careful. These drugs are going to bankrupt our healthcare system if we're not careful. So they also took away the burden of maintaining generic drug prices in Canada because they don't think that's as important. And they want to make stricter requirements to establish pricing, revenue, research, and development expenditures from the patent holder companies. And they're going to require all patent holders to disclose all third-party discounts and rebates on all monopoly drugs. And this is part of their system to try and control the costs. So after public consultation, this amendment is currently undergoing review and is subject to review by the Government of Canada probably this next year. So there are two key controversial pieces to this. One is this cost utility analysis, and that's again looking at basically an analysis that comes up with basically an ICER score, which is this incremental cost effectiveness ratio. And basically what it does is it looks at the amount of life adjusted life quality gained year versus the current drugs. And it's going to be calculated for every new drug and then compared to the current standard of care to see if the pricing is in line with the mandate of PMPRB. And it's going to be tasked through its own evaluations to adopt an ICER threshold and determine the maximal list price for every drug. The second component of this is they're going to require an amendment that all patent holders report all third-party discounts and rebates. So pharma manufacturers are increasingly negotiated product listing agreements that have confidential pricing and rebates tied to drug expenditure, utilization, and outcomes. And although these may result in deals for some people, the Canadian government feels that this results in unattainable price discounts to individual payers and can clearly hinder the collective purchasing process at a national healthcare scale. So they're going to require very strict revenue and research and development expenses specific to each drug, because right now there is a big, oh, this is what we spend on R&D, but they're not required to do it for each individual drug. So the Canadian government is going to mandate that they have to tell them what their actual R&D costs are for each individual medication, and then they're going to use that in each drug to set a maximal listing price. So the goal was threefold. One is to allow the companies to make a reasonable return on their investment, but not to make an unreasonable return on their investment. Number two, they want to allow access to these new products to patients who need them. But number three, they need to maintain accessible, affordable, and sustainable health care for Canada. And that's their main task. So now what can we do? Our system is under sort of crossroads with costs as well. Current estimates of healthcare costs are about 21% of our gross domestic product. We're the #1 healthcare expenditure in the world in terms of cost, but the best list, we're number 31 in quality. So there's certainly a disconnect between what we're spending and what we're getting. It's clear that the costs accruing in our current system put us at great risk because it's financially unsustainable. So the question is, what can we do? The Canadians are attempting to do this via national committee. I don't know what we're going to do, but obviously our system is at risk.
Yeah, well, what this is going to do is make costs even higher in the U.S., because the rest of the first world is going to say, we're going to set a price, and most of these drugs are developed in the U.S. and made by U.S.-related manufacturers, so for them to continue to make an outrageous profit, they'll just have to charge more in the U.S. if it's going to make less in Canada and the other 11 countries.
You know, again, I don't see that there's an easy answer, but I do see that we're heading in a pathway that we can't sustain. So, and I don't want to sacrifice healthcare in our country any more than it's already been, but at the same time, we have to find a way to make this so that it works out for everybody involved. And right now, clearly, we are the most expensive drug expense in the world, and the Canadian government dropped us as a comparator because our prices are so out of line with all the other, as you said, first world countries. So something is clearly amiss. Whether this is something we can control, we can't control, and can we control it locally, regionally, globally? Do we have any way to control this? I don't know, but I spend an inordinate amount of my day arguing with insurance companies about getting paid for drugs that are super expensive. And, you know, I don't have the time or the energy to deal with that, and I don't want to. So my staff, unfortunately, bears the brunt of my frustration, so they have to deal with it. And then, you know, half the time the answer is no. So it's like you spend all this time, you're told no, they won't pay for it anyway. So we can get compassionate release, we can get test doses. If I use the word sample, I'll be killed instantly at my clinic, so I can't use the word sample. But often I can get approval for a trial period of 3 months or something. But then the hope is that they're going to buy it after that. And I think that's the message. So the question becomes, what can we do? I mean, do we just join together and say, we don't like this? I mean, there's a lot of money that's going into this world, and it's coming out with sort of questionable outcomes. So is there a way that we can let the pharmaceutical companies make a reasonable profit so they stay in business? But is it something that we should all have to pay for out of our pockets? And I'm not sure that's the answer that anybody wants to give. So I invite criticisms, comments, hostility, that's okay. But our current system is unsustainable, and the Canadians are feeling that now as well. So they've been relatively insulated, and now they're not. So, Len, you and I are the only ones that are speaking out.
Well, it'd be interesting to see how, European countries, I think they have federal organizations that just say this is what the drug will be priced at after using certain metrics. It starts to become a political issue. I don't know how this is going to be done in the U.S., but people younger than you and I will have to work it out.
Do you have any physician committees or representatives working on this? Or?
In Canada, it's about half the committee is actually physicians and clinical people, and the other half is economic people.
But
So
do you know any such committees or anything in the U.S., like representatives?
I don't know anybody in the U.S. that's doing this. Actually, I know a lot of work going the other way, who's trying to get around this, but I don't know anybody who's actually trying to do this. So it's not a very popular topic in business at this point. So it's only popular among us healthcare people that want these drugs to be available to our patients. It's not, there's no movement at this point on any national front to try and do this other than they're trying to get transparency in drug pricing. That's really the first step in all this. And that may be the beginning. I just don't see it. There's any real organized effort to force the price of drugs.
They're busy chatting at the end of the day. Till 10 o'clock at night.
Well, I don't like anybody telling me what to do. So this is another place where somebody's telling me what to do, and I just get frustrated. I was also going to talk about vaping-related illnesses, and the more literature I read, I mean, it's just, we don't know anything about vaping. So there's 1,604 cases so far. As of September, 34 deaths. When you analyze all these products, at least half of them contain THC, whether they say they do or not. And of the three chemicals so far, vitamin E acetate, vitamin E oil, and THC seem to be the three chemicals that are sparking the most interest in vaping-related illness. And any of them can cause this, but I got a patient referred to me with, quote, new onset lung disease, and the guy didn't tell anybody he was vaping all the time, so I saw him in the parking lot in his car.
Oh my God.
And then I said, what are you doing? And quick, I didn't do that. You know? And then anyway, so he ended up in the hospital with this typical pattern of fevers, chills, feeling terrible, horrible lung function. And of course his parents were just ready to kill him because they didn't know he was vaping at all. And then I read this data, and we're no further towards an answer than we were 6 months ago. It's just now the number of cases is over 1,634 deaths. So those three chemicals seem to be the main concern, but there wasn't anything else really to put in there. So.
Thank you, Paul.
So, in response to your earlier presentation, I just want to remember what Voltaire said. Physicians prescribe medicines about which they know very little, for diseases about which they know even less, for patients whom they do not know at all.
Some of those timeless statements are just as accurate today as before.